Hello, everyone, and welcome to episode 270 of the Ortho Eval podcast. I'm your host, Paul Marquis, and today we're going to be talking about laser therapy in orthopedics with special guest Dr. Mark Callanen. We're going to be talking about what laser therapy is, the mechanisms of how it works, diagnoses treated with laser therapy, and we'll talk a little bit about insurance reimbursement and so much more. But if you don't mind holding for a moment, we're going to hear a word from our sponsors. Welcome back. So, folks, we have a loaded episode today. We have a lot to go over. And now I used to teach modalities up at a local university to athletic trainers, and I know a lot about your hot packs, cold packs, ultrasounds, e-stims, iontophoresis, all that stuff. But I will be brutally honest with you. I know zero about laser therapy. And so what I did was I brought in an expert to help us today. And, so we can understand how laser therapy works, when we would use it, when it's indicated for certain types of problems. So with me today, I have Dr. Mark Callanen. And prior to joining Chattanooga's marketing and clinical education team, Dr. Callanen treated orthopedic patients and managed therapists in an outpatient setting for 18 years. He has been board certified as an orthopedic clinical specialist by the APTA since 2003 and graduated with his transitional doctorate in physical therapy in 2007 from Marymount University in Arlington, Virginia, after earning his Master of Physical Therapy from Shenandoah University in 1999. Now, Dr. Callanen acquired his therapeutic laser acumen after joining Lightforce in early 2017 while serving as their Director of Clinical Development. Lightforce was acquired by DJO Chattanooga in December of 2020, where he is currently serving as the Director of U.S. Marketing and Clinical Education for the DJO Recovery Sciences Division. He has made formal presentations to mixed professional audiences, both nationally and internationally, on the topic of laser therapy and has begun lecturing on the topic of shockwave therapies in 2021. Dr. Callanen is also currently serving as an adjunct professor for Belmont University's physical therapy program in Nashville, Tennessee. Mark, welcome to the show.
Paul, it's quite an intro. Thanks so much.
Well, Mark and I were introduced to each other through a local company called MedCore Professionals, and they're a DME company, great group. They introduced us to shockwave therapy, which we've been utilizing and having great success with. And we were throwing around, laser therapy a little bit, or you guys were, and I had no knowledge about what it was. And I figured, well, I'm going to start asking some questions. I want to learn a little bit more about this. And I figured, you know what? I'm going to bring you, my listeners, in on this, and we're just all going to learn together. So with that being said, I'm going to move the mic over to Mark, and we'll talk about, laser therapy. Are you ready, Mark?
Yeah, and I would point out before we get started that when I joined the Lightforce team in 2017, as pretty much a manual therapist, used very few modalities in the clinic. I didn't know anything about laser therapy. So I started from, pretty much scratch, and they were interested in me for my management knowledge and knowledge of the space, just being in the outpatient world for as long as I was, and sort of rolled the dice on me. So I spent a lot of time looking at different journals, talking to folks. We were luckily, had a very, very good group of folks. Our CEO, Brian Pryor, who's a PhD and pretty much created our high power laser, and our chief technical officer, also 25, 30 years in this space, Luis de Taboada, was able to pick their brains a lot. And so by basically being around smart people and reading a lot of journals, kind of got me where I am today on what I know about this stuff.
Excellent. So we're going to jump right in. So can you tell me what high power laser is? And please tell me that it's more than just a complicated heating lamp. And,
yeah.
If you can describe this to us. Now, I know today you probably have a few pictures for us because we are going to post this on YouTube also. So for those of you who want to kind of take a look at some of the visuals that Mark has, you can jump over to YouTube and check that out. But while we're going through that, for those of you who are just listening, we're going to do our very best to just describe it for you as we go. So, Mark, high power laser, what is it?
Yeah, so in the US here, the FDA basically qualifies laser based on the power output. So if you're over, the average power output is over half a watt or 500 milliwatts of power, you jump into what they call class 4. And class 4 is basically anything from half a watt and higher. So you could have a laser that put out 500 watts, it's still going to be class 4. So we fall into the same grouping as, different types of surgical lasers and things of that nature. We are a therapy laser company, and that's what the equipment's designed to do. But sometimes that information gets falsely put out there that, oh, if you're using a class 4 laser, it's dangerous, it's going to hurt people. It's not true. It's just the nature of the power output. It has to be managed by the device. And, we can get into that in a little bit. But if you go down to, class 3B and class 2, these are devices that are much lower output on wattage, milliwatts actually. And due to the nature of the fact that they're lower power, it does not create a sensation of heat on the skin. So when you put the lower power lasers, which are considered cold lasers, that's a sort of a garbage term that got, put out into the space a while ago. That's why they called it that, is because you can put it on the surface of the skin. And because of the lower radiance, the lower power density that's put on the skin, you can't feel it. So people will often say, are high power lasers cold lasers? And technically they're not, because you will feel warmth on the skin as the melanin and the different pigments of your skin absorb the light. They will get warm because of the higher power. So that was sort of the initial differentiator between the two. But all lasers fall underneath an umbrella, and I'll share my screen here to help with this, under a term called photobiomodulation. And this has been a term that's been accepted in the laser space since about 2016 actually. And what it just states is that when you put light, whether it's from a laser or an LED, that basically the body has the ability to absorb that light depending on the wavelengths that are used. There's different things called chromophores in your body that they're sort of the light accepting components on the cells. And as they absorb the light, it creates a change in biological function and has physiological changes on the tissue. So to your question about, is it just a fancy heat lamp? Does it create heat on the skin? The high power lasers? Yes, but this is kind of the mechanism on what's going on below the skin.
All right. Now, there are a lot of folks out there that are watching that are going to want to know if there's a lot of research behind this. Can you fill me in on the research that's being done around laser?
Yeah. When you look in PubMed, say, and you look under laser, you're going to pull up things, for different types of surgical lasers, different types of lasers used on eyes, and a whole bunch of use, even maybe some different technical type lasers. So it's very important to use the correct mesh headers when you look. So photobiomodulation is now the accepted mesh header for laser therapy. So if you put in photobiomodulation and say low back pain and shoulder pain, you're going to get the most recent research. And so I just put in photobiomodulation, and 3,600 papers or sites came up on PubMed. And then when you put in LLLT, which is an acronym for low level laser therapy or low level light therapy, it's not quite clear on which one is used and when it is. That was the reason that photobiomodulation came about as the naming accepted mesh header. That's been around for a lot longer, and 8,000 plus hits came up for that. So if you combine those two, there's over 10,000 papers that are out there on the topic of therapeutic laser, and the number has been growing sort of like a hockey stick over the last 4 or 5 years based on some of the things that they're starting to find out. Nice,
great. Now, we have a lot of folks who are physical therapists, occupational therapists, PT, OT assistants, athletic trainers. We even have, orthopedic surgeons who listen to our podcast. Can you talk a little bit about some of the diagnoses that can be treated in the realm of orthopedics? And if there are other diagnoses like, diabetic issues or neuropathy problems and things like that, can you talk to us about some of those diagnoses that you see most often used with laser?
Yeah, so the indication for most lasers that are out there, including ours, are for helping with pain on the musculoskeletal level, basically. So for OA, muscle pain, anything that's sort of on a myofascial level, due to the heating aspect and the fact that it does help address pain to come down, that's the sweet spot for light force therapy lasers. And you can apply that to OA at the knee. You could apply it to a strain in a hamstring, low back pain, anything that's involving, a nerve that's irritable. The laser has the ability to interact with that to help with that problem. So think of it as a very diffuse musculoskeletal tool that you can use in your clinic.
Is it something that you typically use before or after you're done treatment? Like, let's say you're doing some exercise with somebody, would you prep them with laser, or would you kind of finish them off with laser? Is there a preferred time during a therapy session that would be most beneficial for them to use it?
So I would say the more acute presentation that you're dealing with, the more you'd probably want to start with it, because the laser has the ability to impact pain. The effect it has on peripheral nerves, C fibers for chronic pains and A delta fibers for acute pains. You can basically impact that signal that's going back to the cord in almost like a true analgesic way when you get high irradiance or high dose to those those afferent nerves. So that's why it's an effective tool for both acute and chronic problems. But if you treat, say, a shoulder, that's really guarded, and you use the laser first, you might find that you pick up quite a bit of range of motion or decrease pain when you're doing your range of motion work with that person because of its ability to impact that pain. It's worth reemphasizing that in order for that to happen, you need to have high irradiance or high power, because if you're below the threshold to create these changes in these afferents, then you won't get that quick change. With lower power dosing, you generally can get impacts on pain via its mechanisms to impact the inflammatory cascade and better blood flow to the area, which will impact mediators such as bradykinins, things of that nature that will impact pain. So it's not uncommon, even if you're using a low power laser, that within a day or two, the person comes back and says, hey, I'm feeling better. That's kind of that mechanism. But for that quick change, if you had a high power device in your clinic, I would want to use it early. But there's also an argument at the end, say you had somebody who was more on the chronic side of things and you worked them out pretty hard, you did a lot of manual therapy, and you want to try to maybe get it so that they're not as sore. Because of the increased blood flow that the laser creates, if you did it at the end of treatment, the chances are they're probably not going to be as sore the next day. Our devices are used in Major League Baseball a lot to help control DOMs. So what they're doing with their throwers is they treat before they throw, and that helps address the sort of the fatigue characteristics of muscles. And they've done some great work on this at the University of Florida and the University of Tennessee, looking at how it impacts that. But basically, DOMS is a two-headed dragon. It's got your mechanical problem and then the chemical problem after the event. So if you can get better conditioning of the muscle and get less shearing on those actin-myosin interfaces, you're going to get less cause of inflammation. So the trainers that are really on top of it that use our stuff, they're hitting the thrower's shoulders a couple hours before they pitch, and then they treat them again after they throw, and that helps address blood flow and get better repair from the chemical aspect of DOMS that takes place. So for that, in those instances, they're using it, I guess you could say, before and after, but the rationale is that it's still helping control some of those pain characteristics that are associated with DOMS, and it works great.
Sure. Now, when a patient comes in and you want to introduce them to laser, you want to do some treatment with them, how do you explain it to them how it works in a layman's term? Now, when we used to use a lot of ultrasound and things like that, we talked about how the mechanism works, but we can kind of like make an analogy to something else that makes it easy for them to understand. Is there anything that you utilize with patients that makes it a little easier for them to not buy into it, but feel comfortable having it? Because somebody came to me and I'd never had it before. I'd be a little skeptical, maybe a little afraid. You want to use laser on me. I mean, I'd like to understand that, why and how it's going to help me. How do you kind of present it to patients who are getting it for the first time?
Yeah, that's a great point, because when you mention laser to the average person, they might envision Luke Skywalker's lightsaber, or lasers coming out of a spaceship that are blowing up things. And you have to sort of back them off of that mental cliff. So saying, hey, this is a modality that's been around. It was FDA approved in the 80s, basically, in the US. So it's been around for a long time. The science started in the 60s on this whole thing. So it's been around a long time, but it's a non-invasive, non-pharmaceutical way to address pain. So we can put this light on you. It's going to feel warm. It's not going to hurt. It's going to feel comfortable and soothing, actually. And when we're done with the treatment, likely you're going to have less pain and you're going to move better. So it'll make my life easier. I won't have to push as hard on you. I won't have to do as much, grunting type of stretching and things of that nature when we do your treatment. So it should make everything a lot easier, and it's going to help things, move along because of the increased circulation. It provides tissue. You're going to heal quicker. And basically, That concept is why our devices are adopted in pro sports and college sports so well. So it helps with the recovery process and getting people ready to get back on the court sooner than they would otherwise. So, sometimes if you're treating, say, an ankle, somebody comes in with a sprained ankle and APTA in 2021 added laser as a recommended tool to use on acute ankle sprains for pain and improving mobility as a modality choice. So it's clinically supported from JOSPT. But I would tell them, say, have you ever watched a pro athlete go down with a sprained ankle and you see them that they're playing again in like 4 or 5 days? Have you ever wondered how that happens? And using technology, there's several that are probably involved, but one of them is most likely laser, helps bring things back, to homeostasis a lot faster. So if you don't use that stuff, you're probably going to get better eventually, but it might be a lot longer. So it's time is money, and when you have a patient in front of you, you're trying to ask them, as much as they probably like seeing you, like coming to your center with your friendly staff and what have you, they would probably rather not be there. So when you can paint that picture like, hey, this is going to help save you time and effort because you won't have to come as much because you're going to get better probably sooner than you would if you didn't use this. It'll save you on copay. It'll save you on, just transportation costs and time from work and babysitters and all that stuff. From a convenience standpoint, often people are very attracted to it.
Yeah. Now, I know some of you out there are going to be saying, wow, this guy is really old. He doesn't know. I like talking about me, that is. How is laser
You and me
applied to a
both.
person? We're very experienced is what we're going to throw out there. And and wiser. And how is it applied to the person? Do you, is it like a disc? Is it like a flashlight? Is it like a wand like you would utilize with an ultrasound? How does it get applied to the patient? And how do you know what kind of dose to use? Does it vary with the diagnosis or the chronicity or acuteness of the diagnosis? Can you explain that a little bit about the physical use of the laser?
Yeah, a couple things to unpack there. So the actual device, most lasers, especially the higher power ones, there's a box, a chassis that has the diodes in them, which are solid state, components that basically create the laser. Then those are basically focused. They go into a fiber optic cable that goes out to a handpiece, which then is what applies the light to the surface. So the handpiece is a very important piece of the discussion because it will dictate the dispersion angle of that light that comes out. If you think about it in terms of if you had a laser sight on a rifle, the dispersion angle on that is pretty much zero because they want that dot when you point it hundreds of yards away to be the same size as if you point it on something that's 10 feet away. So by the purpose of that, it'd be the same if you had a laser pointer, the dispersion angle on that is zero because you want to be able to keep that little spot when you're looking at things, from far away.
Sure.
From a therapy standpoint, that would be very dangerous to do if you had a dispersion angle of zero on your laser, because if it were to get too hot, one of the remedies is that people can move the handpiece up away from the surface. And if you have a dispersion angle, say 40, 45 degrees, as you pull it further away, the spot will grow and the intensity of the heat in that spot will go down. So from a safety standpoint, almost every therapy laser has a dispersed beam for that reason. There are other mechanisms that you can utilize to control heat on the surface, like pulsing or the speed that you move it back and forth. Like for Light Force, our newest smart handpiece, it basically has an accelerometer in it, and it will measure how quickly you move it back and forth. And we know based on our research that if you keep it going 2 to 3 inches per second, it's going to be very comfortable with the correct unit on the handpiece, the head that you're using. And so it'll actually tell you the light will be green when you're doing it right. And if you go too slow, it gets red and it'll vibrate, which lets you know, hey, speed up a little bit. And if you go too fast, it'll get yellow until you slow down because you want it to have enough time to scan the area and go back and forth and get enough photons to the scene to make a change. So there are lower power devices that are out there that sometimes are just a single handheld unit. You'll see those and you'll see those in the clinic. They don't have the same problem with heat. As you produce more power and you have multiple diodes, it creates a lot more heat. That's the one thing for the laser, not just in the handpiece on the skin, but in the actual box where the magic is happening to create the energy that goes into the handpiece. So we've, spent a lot of time in our R&D to make sure that that thing stays cool. And so as a result, you can turn the machine on in the morning and you can use it all day long on patients and turn it off at night, and it's going to function really well. There are some products out there that have been sort of converted from, say, a dental laser and tried to make it more of a therapy laser. And they have a very small chassis, small box. They don't have as robust a cooling system. And what happens is that in the mouth, because the tissues you're addressing are very superficial, they're usually a pulsed beam and it's low power because you don't need a lot of that to address the gums and things of that nature. And they work great. But when you're dealing with, say, a hip or a back or a larger area, you have to generally use the device a lot longer. You may want to be using higher powers for that because of the treatment times involved and getting irradiance at depth. So what they found is, or what we've seen over the years, hearing from different customers, is that when they try to use those devices for longer periods of time, they tend to overheat. So if you guys are out there shopping around looking for something, definitely want to keep that in mind as far as just the heat aspect. And you want to ask the person, hey, how long can I use your device before you don't need to take a break? And that answer might be very different from device to device, depending on what you hear. But the global answer is they come in different forms and different shapes. Power will generally dictate a box with a cable and a handpiece. And then there are certain devices that are now starting to get into, unattended deals where they'll have a mechanical arm and then they'll have the handpiece at the end that'll basically pulse and maybe move back and forth. But they generally do that at lower power to control heat and be safe. So it's just a question of understanding what you're trying to get done and what you're trying to get out of your device so you get the right one.
Sure. Any problems with, burns, like a sunburn type of thing, or what are some of the contraindications to utilizing laser?
Yeah, so knowledge is a good thing. Our devices are used for about 1.5 million treatments a month around the globe. We've never had a serious report of injury. The couple that have had some skin, injury due to heat were due to improper use. One person, I remember, they had put essential oils on the skin and then treated with the laser, and that obviously changed the absorption characteristics of the skin, so that person got blistered. But it wasn't because of the device. It was that they applied something on the skin they weren't supposed to. So generally, the nice thing is if you have a patient in front of you that has normal sensation, sharp, dull, hot, cold, lateral spinal thalambic is in good shape, and it gets too hot, the patient's going to tell you, hey, it's getting too hot, and then you're going to move it away, and everything's going to be fine. But if you do have a patient that's got a neuropathy, and they have impaired hot, cold, impaired sharp, dull type sensation, those are the people you want to be more careful with, not use the higher powers, use more modest powers, possibly even pulse the device just to control for the temperature of the skin. But to answer your second question about contraindications, generally it's a very safe modality, very low risk. There's a list of contraindications that are on almost every modality, and they've included a lot of those with laser. It's not that there's tons of research to say if you do this, it's going to happen, but from a manufacturer standpoint, we have to be very conservative with what we recommend. So growth plates with children, they recommend not treating over those. So that's the distal ends, the long bones, hands, feet. You would probably not want to treat with a younger person. We get asked frequently with like Sievers or Osgood Schlatter's, which is directly over a growth plate. You wouldn't want to treat that with the laser for that reason. You could treat around the space, but not directly over that where you visualize that growth plate. Pregnant women, you wouldn't want to treat over the belly, low back, or SI area. Again, there's never been a study that said it's going to impact your fetus, but I don't think too many people are going to sign up for that study.
No,
so
right, exactly.
It's sort of a common sense one to stay away from. A known cancerous tumor. So if you had a melanoma on the skin, you wouldn't want to treat over that. When you start talking about treating for post-cancer, lymphedema, things like that, that's a different animal. And that's a discussion with the oncologist and the patient and making sure everybody's on the same page. But there are uses and studies that have shown can be applied for things in that nature. Oral mucositis is one that happens for people that have had throat cancer and they have to get radiation. They get these really nasty red sores in the mouth. There's actually an indication for laser for treating those with devices that are designed for that to help with that, and it works really well. So cancers, if it's a known localized lesion, nope. If it's more of some of these other things we're talking about, that's a question for the oncologist to make sure that they're okay with it. But that's a slightly different category. Also, if they have a sort of a lymphoma or something that's a systemic cancer, then that, again, it gets kind of gray, and generally would say defer to the oncologist on that.
Right.
Short of that, though, those are the big ones. If patients are on photosensitizing meds, so if they're on a Medrol series or antibiotics right now this time of year in the wintertime where people are sicker, those can tend to be photosensitizing, which would mean they're more likely to get like a sunburn reaction to the laser. So you'd want to know what meds your patients are on. If you're not sure, you can do a Google search in about 5 seconds and put the name of the med in and just put photosensitivity and hit go, and it'll tell you if it is or not. So if they are, you probably want to hold on doing the laser while they're on that medicine. And if they say, no, I still want to try it, then that's a discussion you want to have with them and let them know, hey, your skin's a little more likely to get red. And you probably want to treat with a lower power, lower radiance to minimize any chances of problems with that.
Yeah.
I think those are the biggies.
Yep, nice. Now, as a therapist like myself who works in a fairly busy clinic, one of my questions would be, how long does this treatment take typically, and how often do we do this treatment in regards to frequency? Any thoughts on that? Is there a big variability in regards to the time, or is it pretty standard across the board?
That's a good question. So let's go to the video images. So for those of you that are listening, I apologize, but basically this graphic will help a little bit, and I'll try to walk through. But when you're talking about dose with laser, you're really talking about 4 categories. One is the wavelengths that are used. That's a very important aspect of it. The device you use is probably going to dictate a lot of that on which wavelengths are going to be utilized. So do your homework before you buy the thing. And the second will be the power density, which is a function of the power that you use and the size of the spot that's applied. So the irradiance, excuse me, the irradiance is what that's referred to. The overall joules per unit area, or joules per centimeter squared, which in the literature is referred to as fluence. That is the next component. And then the last is frequency. So how many times a week, like Paul just asked. So on that last point, frequency, I would state the research is clear about one thing, is that if you treat a couple times a week as opposed to once a week, you'll get better results. They haven't nailed it as far as, for this condition, it's this many times versus that many times. But if you stack up the papers on ones that apply the laser, say once a week, versus ones that apply it 2, 3, 5 times a week or more, the ones that have multiple treatments will respond better. And you're really trying to address, we didn't get into the mechanisms and what have you, but you're trying to address mitochondrial activity. So think of it as like you have a battery in a car that needs a jump start. Think of the laser as sort of the cables that come in and help jumpstart cellular activity from the mitochondria, essentially. And by doing so, it's going to help cells hopefully not go into apoptosis, which is going to require them to basically be scavenged up and replaced. If you can save sort of the foundational units in the cells that are around the area to not die, it's going to require less time to get the whole system back in order. So that's part of the magic there. But also, the fact that you're trying to stimulate activity and ATP production, if you can just kind of layer that a couple times a week over these cells, it helps keep the pump primed up, basically. So I think that's the big reason why multiple treatments work better. Generally, this thing's sweet spot is in that acute, subacute window. So once tissue moves forward, and you have to understand, it does block pain, so we talked about that earlier, but it's not like taking an NSAID where you're artificially blocking the cascade, which has negative ramifications on tissue healing. As far as, we've done papers on hamstring strains, and when they give NSAIDs early on, their likelihood of re-injuring goes way up because it impacts, the different satellite cells and things that are laying down new collagen for those hamstring injuries. So you don't want to interfere with that. The nice thing about the lasers, it doesn't. It's just moving the process along faster. So if, an acute inflammatory cycle takes 5 days, it might shave off, 20% from that, or maybe more. Who knows? It depends on how healthy the person is and, the depth of the problem and how big the problem is. So all those things would impact it. But multiple times a week is the way to go. The next question is for dose, when you're talking about power and how it impacts things, and that's what I put up here on the screen, is that if you have a known dose, which is joules per centimeter squared, and for your average, your average orthopedic problem, a number around 10 joules per centimeter squared is going to be a good number. So let's just use that for this example. That would be like if you're trying to treat a bicep or a calf or maybe an anterior shoulder, this would be an appropriate dose. And then area is the next area or the next aspect you have to consider. So if you have, say, the area of your flexor forearm area, and you wanted to treat from the wrist all the way up to the cubital area, you're probably looking at about 300 centimeters squared. So the palm of your hand is about 100 centimeters squared. So you can sort of estimate that if you sort of count it off on your chest or count it off on the arm to get you a ballpark. So if you had an area the size of the flexor surface of your forearm and you wanted to treat it at 10 joules per centimeter squared and your laser only had, say, 1 watt of power to put out, that treatment would take 50 minutes. So that's not very clinically applicable on a day-to-day, right?
Definitely not feasible, especially in a situation like mine.
Right. So, and that's the case for everybody for the most part, unless you have a very, very special practice. But if you had a device that could go to 3 watts and the same things were true, 10 joules per centimeter squared for dose, 300 centimeters squared for area, you could reduce that treatment time to 16 minutes, just a little over 16 minutes. But if you then had a device that had 10 watts of power, you could do that same exact treatment in 5 minutes. So having higher power can really make the clinical part of applying this much better. And I'll warn you, like what happens to a lot of folks is that have these lower power devices. They go, oh, well, I don't really have 50 minutes to apply this to somebody. So what I'll do is just try to do this for 5 minutes or 6 minutes and hope for the best. And I can let you know that like the dose is real important. And a lot of the bad research that happened early on in the laser world was because of underdosing. So think of it as it's like a threshold phenomena. You have to get enough light to move the needle past that threshold.
Yep.
If you fall short of it, then nothing really happens. So those are the studies that go, didn't really work. Well, the question is, did it really work, or did you just not apply enough to make it work? So that's where having the right amount of power to get dosage in very easily is important, because we know in the clinic we get busy, we're hustling, we're like, man, I think this would work for somebody, but I just don't have enough time to do, 10 minutes or 7 minutes. But if I could maybe just do this for 4 or 5 minutes, I could do it, and I think it'll help them. So I'll just try it and see what happens. Those are the type of decisions that are hard, because in your head you're like, oh, I remember that guy said I need to do it for this much for that problem, but the device can make that problem a lot less of a headache. So like our highest energy platform is a 40 watt laser. So you could provide a treatment like this. If 10 watts is in 5 minutes, you could do the same treatment with 40 watts in like less than 2 minutes. So just understand there's tools out there that can make the clinical part very easy. And I would let you know that higher 40 watt laser with the higher irradiance, that part we talked about earlier about reaching that threshold for changing pain quickly, does it beautifully. So from that standpoint, getting the, wow, that really helped. B, that decreased pain is going to help you range that person or have them be able to ambulate or put weight on something that might otherwise be really a challenge. All those things are going to factor into the impact on how it's going to, address how you care for that patient that day. Sure. And, on that point, the last thing I'll say is that I was at the PPS conference out in Aurora, Colorado a few weeks ago, and got in a pretty heated conversation with a gentleman about how these modalities impact pain and is it really helping the problem. And his argument was like, if you're just masking pain and then they go do stuff and they could possibly hurt themselves, or it's not really doing anything. And the point I was trying to make to him is like, look, you don't take off your clinical thinking cap because you applied laser on something and the pain is less. You still know that you're dealing with a strain or a capsulitis or a whatever that you're addressing. You still have all of that knowledge in your head as far as how long that normally takes to get them to a higher level. But it's the name of the game with what we're trying to do is to push function, push range, push things to get them back to a normal place. And my argument is like, if you can get some reduced pain, which allows them to get a normal mechanic, whether it's in a shoulder or in a in a leg or a foot or a knee so that they're now walking better or they're ranging better. All that stuff is then going to be tempered by how you provide the exercises and the plan around it. You still, I mean, imagine if your biggest headache during your day was you had to put the brakes on your patients, right? Hey, I know you feel a ton better, but I need you to not do too much. And that is actually part of the narrative you have to have when you're using these things and you get really skilled with them, because patients will think that they're healed. Oh, I feel so much better. Now I can go. Especially your runners. We know they can't wait to put the shoes on and put in 5 miles. So you have to tell them, hey, that tissue's still on the mend. This is helping it happen a lot faster, but you still got to respect it and give this some time to come through so that we can do some other tests and make sure that you're really in a place where you can handle that kind of volume, that kind of load.
Yeah, absolutely.
And,
we have that chat with a lot of patients, and just because you're feeling better doesn't mean you're healed. And yeah, I totally agree with you on that.
So on the first topic of wavelength, that's an important one because that's one that gets talked about a lot, and I think it's used as a talking point to confuse the general public more than to help them. But the mechanism for absorption, the molecule that gets absorbed, that's been studied the most when it comes to laser, is cytochrome C oxidase, which is the fourth ribosome on the electron transport chain. So it's in the mitochondria, and basically that has little elements. There's actually 7 different ones on this that can grab light. And so it has the ability, though, to respond to a lot of different wavelengths in this near infrared spectrum that therapy lasers tend to live. So from about 650 to roughly 1100 nanometers, maybe 1200, depending on which scale you look at, that's kind of the window where therapy lasers live. And the best absorption of this cytochrome C oxidase happens in the red range, the 650, 600 range. So that's why you see tons of these devices. They're like, oh, red light, it saves the world. And if you were trying to treat patients that lived in petri dishes, you'd be right on. You'd have the right wavelength to get the best absorption from cytochrome C oxidase. But what you want to understand from this graph, it's just basically showing that from 600 to 1,000 nanometers, and it ended at 1,000 because that's where this device stopped measuring. There's the ability to absorb light. There's a peak around 600, 650, but then it kind of flattens out as you go from 700 over towards 1,000 nanometers. So anything in that range can do it. The thing to understand is that when you're dealing with humans, you have to get through the skin. And so there's melanin there, there's hair, things that grab light. So, and they also get hot. So if you used a 650 nanometer laser and that was your only wavelength and you were trying to dump a lot of power into it because you remembered, hey, higher power, I can treat faster, probably what's going to happen with your patients is they're going to tell you that's way too hot. I can't tolerate it at the higher power, because you'd be getting so much absorption of that light at the skin where you have all those sensory nerves for temperature, that you wouldn't be able to use the higher power because it would be uncomfortable unless you were pulsing it or doing something else. So because of that, it's not just the temperature part that would be a problem. It's a matter of light getting through the skin to get to where you want it, because that's the science behind this, is like, how do I get light a couple centimeters into the body to have it do something? Like when you sit on the beach on a sunny day, you're getting thousands of joules of energy on your skin, but you're not creating photobiomodulation. Why? Because the wavelengths that could actually do something, there's not enough concentration of it. There's not enough irradiance to get it to where it needs to go in an adequate dose to make it happen. So you can sit on the beach for all day long. You're not going to probably impact your arthritis in your knee by saying, hey, I'm getting photobiomodulation. Now, are you affecting possibly psoriasis on your skin or something like that? Yes, that's a different topic, different discussion. But for getting light down below, you can't. So understand this heating effect. It happens because of a lot of absorption at the skin. That's what it's designed to do. But the heat that takes place below the surface of the skin with therapy lasers, even the high-powered ones, it's minimal. Like, so once you get, even half a centimeter or beyond into the tissue, the amount of heat is very little, because the concentration of the light at that point is much lower because you've lost so much just getting past the skin. So the wavelengths that do a good job of getting past the skin and impacting the cytochrome C oxidase, that's the important thing. And so the research is supported, and the wavelengths that our devices utilize are 810 and 980 nanometers. And people always ask, well, why do you use those? It's because they help solve this problem. They get past skin pretty well, they get deep, and they impact muscles and nerves really well. And there's been a lot of research to support that. So there's companies out there that go, well, we got this wavelength and that wavelength, or we got 6 wavelengths. It's like, okay, great. The question is, even if you have a wavelength that can penetrate better, the question is it going to get absorbed? because that's the other piece of it. Not only does it have to get there, it actually has to have the interaction with these receptors to make something happen. So some of these wavelengths, they can penetrate a little bit better that are starting to evolve. They haven't demonstrated that they necessarily get absorbed real well. So just be aware of that when they start talking about this topic. And the last piece is that power that we were talking about earlier. If you can just think in terms of this concept of therapeutic depth, which means the brighter the light is you put on the surface of the skin, the more photons you're going to put into the tissue. So if you're in a dark room and you had a 5-watt light bulb on your flashlight versus, say, a mag light that had 20 watts of power, right? A big bright LED. That's exactly what the power game is with the laser. The brighter it is, the higher power. It makes it easier to get light deeper. So this slide I just put up for those of you that can't see it, it's basically just showing a red light laser, 630 nanometers, with a half a watt of power, basically shining into a medium. And what it shows is that there's a really bright circle of intense light that's just maybe a half a centimeter of depth. And when you look at the definition of depth of penetration, and I won't get into it because it's beyond the scope of this chat today, but basically it's a very small level in human tissue. It's like 3 to 5 millimeters, depending on the study you look at. So when people read that and they're doing a cursory check on this stuff, they go, well, wait a minute, laser depth of penetration, as deep as it can get is 3 or 4 millimeters. Like, how's that going to help, a sciatic nerve or help a piriformis that's multiple centimeters deep? And you're thinking right. But you just have to understand that that's a very specific scientific term and has a very defined thing when you start looking at it. But this concept of therapeutic depth is basically saying past that definition of what depth of penetration is, there's still more light that is going into the tissue. And that's what this slide shows. That cloud of light that goes beyond that really bright center, those are still photons. Those are still wavelengths that the cells can absorb. You just have to think that the concentration of that is a lot less. So you have to put a lot on the surface to get that sort of cloud of light below to be significant enough that it's going to impact change. So that's in a nutshell, as far as getting to depth, why having higher power helps a lot, because you can put this bright light on there and that cloud will basically be larger and brighter. And it means that you'll have to spend less time to make an impact at those deeper tissues. So,
and for those of you who are just listening to this but want to look at it, I'll put the link to the YouTube channel on here so that if you want to go take a look at some of these pictures, it's just really they're very descriptive and will really show you what we're talking about today and will be helpful. So be sure to check that out.
This slide, the reason why I like using it is I gave a lecture at Life University a few years ago for their continuing education event there for the chiropractic folks that came from there. And I put this slide up and we had just talked about depth of penetration and therapeutic depth. And we spent 40 minutes talking about this slide. I couldn't believe it. I mean, it's just, it sparked off so many things. And there are so many sort of misconceptions that had been thrown out there from different vendors and what have you. And we were sort of unpacking stuff. And I was just like, wow, this is a better slide than I thought. And I try to use it whenever I can on this topic because it obviously helps paint that picture. So hopefully if you guys can come to the YouTube channel and check it out, it'll help with that.
Yep. Now, do you have any other? Okay, so what I'd like to ask at this point is, and everybody's thinking this, does insurance cover laser therapy?
That's a good question. And it's probably one of the reasons where adoption in the US has been slow with this, as generally we kind of, as therapists, perform like, ostriches with our heads in the sand. If we don't get reimbursed for it, then it must not work. And we don't use it because it's not convenient to bill for it and get it paid for. So insurance companies generally aren't looking for ways to pay therapists more. They're doing quite the opposite. They're looking for ways to pay us less and less and less. And so they don't really want to open up the gates to another thing that they have to pay for, like laser. So generally it's not. There are some examples across the country in the work comp space where it is recognized. And there are some codes. So there's codes that could be utilized for that. But generally you can submit them and then they're going to come back and say, hey, we don't recognize laser. So no, we're not going to pay for it. And when you get that note, we look at that as an opportunity, as a win for cash services, because then you can say, okay, your insurance doesn't cover this, even though we're in network with them. They don't even recognize it. So therefore, we're offering this service outside of that scope. And if you want to add it, you can at this cost. So the national average is roughly about a $50 fee per treatment. It changes a little bit depending on where you live, but that's the average. And people, when I tell them that, go, oh my gosh, I can't even get my people to make a copay. How are they going to spend an extra $50? It's really about explaining it to them, maybe demonstrating it here. Let me show you how this feels and how it works. And then getting that patient to understand it, to buy it in, have them see the results of it. And then all of a sudden they put that math together about, wow, I feel better. I'm probably going to sleep better tonight because of that. Or I'm going to get my arm moving better. I'm going to get back to my golf foursome sooner, or I'm going to be able to start walking with my grandchild faster. And they start putting the dots together to make their goals happen quicker. And you'd be shocked the number of people that go, yeah, I want to do that. So it's just a matter of, you have to have enough information as the therapist to explain it to people and let them know how the thing works. You can't just go, hey, we got this laser and I think it might help. You want to try it? Like, that won't cut it. You have to have at least a minute or so of pitch to say, hey, this is how it works. Here's why I think it's going to help your problem. Let me show you how it works. And then have all those dots get connected. And then after that, if you say, is this something you want to add? That's when they'll be like, yeah, this makes a lot of sense.
Yeah.
So there's a bit of a recipe to it.
Time and time again, we're having this big push away from modalities. From insurance companies, number one, are saying, we don't want to reimburse for any modalities anymore. They stopped reimbursing for orthotics. Now, I started building orthotics, making orthotics for patients about 15 years ago. And, most insurances do not cover orthotics. Patients come in with a serious foot problem and, we put a pair of orthotics on it. They pay cash for it. They leave. They come back in a couple of weeks and say, this is the best thing that has ever happened to me. I got my life back. I'm walking better. I'm more functional. I'm more active. And then for the next, 10 years, 15 years, I've been seeing these people come back every 2-3 years. I'd like a new pair. This is my place for therapy. It really has, its place, although you can't get reimbursed for it. I mean, I had 2 patients recently who had very difficult tendon issues of the foot, and we know that we're going toward loading programs with isometrics, light eccentrics, proper shoe wear, orthotics, and all that stuff. And we put them through this program, and I hit a brick wall with 2 of my patients. And I don't usually, but I did with these folks, and they just were not getting better. And I said, all right, we're pulling out iontophoresis with dexamethasone sodium phosphate. We put it on them, and it was the only thing that we had done differently. Both patients came back the next time, said, I am 50% better. And that is the only thing that we did different. So I want more of it. And so, and we're doing the same thing with RPW. We got an RPW machine. We know the insurance doesn't cover it. We have people who are, chomping at the bit and knocking at the door to pay for it now because we've utilized it as an adjunct to some of our therapy. And some folks just tried it alone and they had significant improvement. So yeah, there are a lot of modalities out there that can be very helpful. Should it be the only tool that you use? Absolutely not, because ultimately our goal is function, less pain, and getting back to doing what you were doing before. And so yeah, I agree with you. I think it's difficult because getting into the modality market and trying to get insurance to cover it is near impossible now, just because insurances are already against us. Doesn't matter what we are using. But I think it can be a great tool and definitely something to explore.
I think it's also worth mentioning, on a couple points, is the number of authorized visits are not expanding. They're contracting. So we're really getting put under the pump to get results with less service and in less time. So with that being said, unfortunately, especially younger therapists, some programs, I think, come at it from an angle of like, you're either a manual person or you're a modality person. And that is totally the wrong lens to look at this type of problem. It's really about what makes sense, what gets results, what helps move things forward. And I think what you find after you've pushed around on thousands of patients like Paul and I have over the years is that, I had a teacher once told me, hey, I'll beg, steal, and borrow for anything that works. And, he was talking about placebo at the time, saying, hey, if the patient buys into what this is and it helps them feel better and it gets them moving right, and placebo is a whole other topic, but his point was don't poo-poo something, that the patient believes in that moves the needle, because everything that moves the needle is a big help to what we're trying to do. So for something like laser, where there's plenty of foundational science to say it helps, to just discount it because it doesn't get paid for, or I don't believe in modalities, which our research shows there's about a 16% segment of PT out there that is in that category. I don't believe in modalities, so I don't use them. I'd recommend don't be part of that boat, because that little clan, that 16%, they're missing it as far as the bigger picture on, how the patients view things and their value, when they come in. The other piece I would bring up is that, remote monitoring, there's some money that's starting to get thrown at that for Medicare. If you do it right, you might be able to make about $160 a month per patient on doing that if you do all the right things. But stop and think about why that's happening. They're not doing that as a favor to the PT world, or to say, oh, we're doing this because we want you to make an extra $160 for each patient you see. They're doing it because eventually where that's going to point is, now that you can do that and you've proven you can do that really well, now we're going to authorize less for the clinic. And that's just my guess. But, being around long enough, I can almost see it coming, right?
Absolutely.
And to understand that, and that this remote monitoring and remote treatment and what have you, it's going to start to change this interaction we have with our patients. So they are going to come in for probably less time. They don't want to be there as long. You might have to do an abbreviated treatment or what have you. And these types of tools that can help change how they feel, like Paul brings up the foot patient that has plantar fasciitis. All they want is to be able to get out of bed in the morning and not have excruciating pain when they load their feet. So if you have a tool, whether it's iono or shockwave or laser or whatever it is that your little magic hands can't do, and it makes them start to see change in some of these problems that, like a chronic tendinopathy, like a plantar fasciitis, we all know that could take months to resolve, right? Even with the best plan of care. And some of this technology that we're talking about, you can start changing their pain complaints in days. So just imagine from a compliance standpoint, even if you're the best manual therapist and you got the best exercise prescriptions on the planet, you're probably not going to move the needle on a plantar fasciitis patient for weeks, just to the nature of how it heals, right? So if you could add a bullet in your gun that could allow pain to get impacted in a meaningful way, where they come back in a couple of days and go, wow, like Paul's patient, I'm 50% better after you did that one ionto thing. I want it again. That's the type of thing that these technologies and this research does. And like we pointed out at the top of the show, there's 10,000 studies out there on laser. Like, it's obviously doing something that people would not continuing to be looking at it. And the body of research is growing in a whole bunch of different areas. So it's not like it's had its heyday and it's dropping. No, it's just kind of getting figured out. Yep. So just because, the initial topic we talked about where you're not getting reimbursed for this, don't take that as it's ineffective, because that's definitely a confluence that's not true.
Yeah. And I think if we look at the safety, when you're adding a treatment to a patient, if you can do it safely, and it's not going to harm them, then you can utilize it, in the appropriate setting. And so I think that, with that being said, boy, we've gone through a lot of stuff today. Mark, is there anything else you want to throw out there before we get done today?
No, I really appreciate the opportunity just to share some of these thoughts. It's always great, hopefully, to reach a few new people to get them around the concept of what, this technology can do. Yep. I'll just put my contact information on the screen. If you want to get any information about a laser and a demo or anything for your facility, you can call our number at 877-627-3858. And you'll get in touch directly with somebody that can set that up for you. If you want to get some more information on laser and how it works, and some different webinars I've done, and different treatment videos, you can go to lightforcemedical.com and check that out under the resources tab. Got all sorts of fun stuff in there that you can check out. You'll be a pro after you watch 2 or 3 of these things. But yeah, if social media, also put those up there in case you want to follow us to stay abreast of what we're doing and how we're doing it. You can do that. But yeah, look forward to hear from you guys, and any way we can help as far as getting you introduced to this, be happy to do it.
Yeah, and I'm going to add those links into the show notes of today's podcast. So if you want to check those out, that'd be great. Mark, I can't thank you enough for coming on today and helping me out with this and educating me and all of my listeners, more importantly. And, I just, again, can't thank you enough.
No problem. Happy to do it, Paul. And hopefully we can talk about maybe RPW or something fun, down the road, and dive into that.
Absolutely. Well, everyone, I hope you enjoyed today's show, and I really would appreciate it if you could give us a rating or review at Apple Podcast, and give us a rating on any of your podcast platforms. That would be great. It just helps us make our show better. And even if it's a negative rating or review, that's quite all right. If you have a question or concern, be sure to send it to me. I'll keep the link in the show notes. Feel free to contact me anytime. And again, as always, I hope you had a great day, and take care. Bye.